Hello and welcome. It's time again for another 3D Organon webinar. The title of our webinar today is Teaching Regional Anaesthesia Anatomy, Sonoanatomy using VR. For those of you who don't know me or meeting me for the first time, I'm Theo, Sales Manager at 3D Organon for Europe, the Middle East and Africa, and your host for today. Virtual reality is rapidly transforming standard anatomy teaching and learning, allowing educators and students to visualize anatomy in an entirely new perspective. The 3D Organon Anatomy software solutions with the applications for VR anatomy, virtual reality anatomy, and 3D anatomy, that is desktop, laptops, tablet and smartphone, are being implemented by hundreds of institutions, education institutions and universities worldwide in their medical education and allied health science programs and curriculums. Before we move on, I think I feel that it is important to state that in terms of conflict of interest and for the purpose of transparency, none of our special guest speakers that take part in 3D Organon webinars receive payment, financial gain, or reward whatsoever. So without any further ado, I would like to extend a very warm welcome and introduce Dr. Boyne Bellew, Consultant Anaesthetist, Regional Anaesthesia Program Director at Imperial College Healthcare NHS Trust, and Honorary Clinical Senior Lecturer at Imperial College London. Dr. Bellew is also a member of the 3D Organon Scientific Advisory Board. He will share his insight and experience in teaching regional anesthesia anatomy, sonoanatomy in VR. Dr. Bellew, I'll pass it on to you.
Well, thanks very much, Theodos. Just confirming my screen is active and everyone would be able to see it.
Yes.
Right. So my name is Boyne Bellew. I'm a consultant anaesthetist at Imperial College Healthcare NHS Trust. You know, I was asked just to talk about our experience regarding the use of VR and the use of the Organon software. Just at the bottom, you can see my email address and Twitter handle for anyone that wants to contact me in the future pertaining to this or anything else. So just as was alluded to, a couple of declarations. I'm a member of the Royal College of Anaesthetists and a diplomat. I'm also a member of the Association of Anaesthetists of Great Britain and Ireland. Also a member of European Society of Regional Anaesthesia, of which I'm a diplomat as well. And with regards to 3D Organon, I'm part of the Scientific Advisory Board, but I receive no funding whatsoever from them for this talk or in any other way, shape or form. And then, yes, I'm a consultant anaesthetist at Imperial College Healthcare NHS Trust and an honorary clinical senior lecturer at Imperial College London. And most importantly, I'm a regional anesthesia enthusiast. So my talk today or discussion will just be around our experience of venturing into virtual reality and the teaching applications that we have used Organon for. Just as a bit of a background, I work at one of the trauma centres in London, specifically St. Mary's Hospital. So the London trauma system is composed of those 4 hospitals, of which I work at one. We're the smallest, but apparently we're the busiest, and we do a lot of regional anaesthesia. This is just a bit of a map that many of you may be familiar with, but that is our 4 hospitals, and I'm mainly based at St. Mary's, and you can see Charing Cross is another hospital that I do frequent as well. Just a nice little picture of the canal and our building for St. Mary's Trauma Centre. Also, we are a European Society of Regional Anaesthesia accredited training institution where we offer a fellowship for those that want to learn regional anaesthesia. So anyone listening out there that may be interested, you can always contact us. Right, so virtual reality and anaesthesia. This was published very recently in the Bulletin of the Royal College of Anaesthetists, and there's the link if anyone wants to have a look. And virtual reality, I think, is going to become part and parcel of medical education. Our surgical colleagues use it, imaging, radiologists, etc. Everyone is venturing into this format of technology, and anesthesia is no exception. So, anesthesia. Well, this is a little, not my picture. I've taken this off the internet, so I can't claim it to be mine, but definitely this is regional anesthesia at its best. It's hours of boredom, minutes of thrill when you're actually doing the nerve block, so to speak, and seconds of terror when the surgeon actually starts and you hope that that nerve block is working. So what is regional anesthesia? I do appreciate there may be people on this webinar that don't necessarily or aren't medically trained and don't fully understand what regional anesthesia is. So just in a nutshell, what it is. Today, you would be generally using a ultrasound, and as you can see, the probe over there, a needle, which is attached to a syringe with some local anesthetic, and you'd have a patient that has consented and agreed to having what we would term a peripheral nerve block. Subsequently to that, you'd be using this ultrasound to generate a 2D image, a lot of black and white dots, and you would then have to try and interpret what you are seeing to perform this nerve block. Subsequently to that, you would then take this needle, that you can see a needle here, this is next to a nerve, and you would then deposit local anesthetic around the nerve. And the basic principle is that you're depositing this local anesthetic where you have a nerve that you can see over here in number A, moving on to B. Normally how a nerve conduction works, the very basics of it is they sodium channels where sodium crosses the cell membrane, elicits a response and causes nerve conduction. Whereas your local anesthetic crosses the cell membrane and blocks that channel. And that is regional anesthesia in a nutshell, what we're trying to do. And that will then allow or facilitate surgery. Regional anesthesia has definitely come to the fore with the COVID epidemic. Why? Well, you can avoid what we call aerosol generating procedures, putting people to sleep. And people can be awake for their surgery or sedated, especially for limb surgery. So teaching regional anesthesia and what as such it entails. And some of the traditional regional anesthesia anatomy teaching methods would entail cadaveric dissection or prosections, where you teach the anatomy in a 3D environment or 4D environment, because you can touch and feel, I guess. And that, I would say, is what most people would consider the gold standard to teaching the anatomical aspects of regional anesthesia and understanding where you're putting your needle, where the nerves lie, and trying to find them to specifically perform the block. But that does have some inherent issues around it, where it's very expensive. It's only in certain laboratories where you can do it. You need access to these laboratories. You need cadavers that are available. And very often, if you want very good teaching aids, you need prosections, and those are obviously very expensive to deliver. Drawings, these can lack detail, very often are just two-dimensional, but not to say that they aren't useful, but that is some of the limitations associated with that. Video demonstrations, these can either be live or recorded, but it can remove some of the practical element associated with teaching and the feel aspect of regional anesthesia. So further on, today, in terms of trying to teach regional anesthesia, ultrasound guidance, I would go so far to say, is really just the gold standard, and most people would be performing a peripheral nerve block using ultrasound guidance. So knowing these machines and how they work is quite important. So that's one of the aspects. You would have to use this machine to get an optimal image and interpret that image. And very often, as I said, for people that are starting out in regional anesthesia, this is a lot of black and white dots. So to understand this 2D image, definitely having been in the cadaver labs, 3D environment or 4D environment, touching, feeling, looking where the nerve needle goes next to the nerve, and then interpreting this 2D image in basically, if you were to look at slices through the arm, for example, you would then understand what this image means. Patient positioning, very important, depending on the type of block you're doing and where it's being performed, aids in acquiring this optimal image and then interpreting it. Recognition of surface landmarks is very important too, so you know where to put the probe, and as such, slide it accordingly to the correct position and finding the correct position when you want to do your nerve block. And then gross anatomy, understanding various regions of the body, the brachial plexus, for example, the lumbar plexus, sciatic nerve, femoral nerve. These are very often areas that we tend to block, and having a good understanding of that gross anatomy so you know where to put your probe on with surface landmarks, generate your image, and then perform your nerve block. And as such, then it boils down to having the sonoanatomy image in front of you, knowing what it is, how it's orientated, and as you can see in this image here, performing a nerve block for a sciatic nerve. This was a very good article by friends and colleagues, Ed Mariano and his group, as such, contemporary training methods in regional anesthesia and fundamentals and innovation. And I think this sums it up quite well, where, as figure 2 there explains from, you have simulation centers, deliberate practice, part task training, where you have phantoms, for example, competency-based curricula, and then the innovative aspects of web-based learning, something that we've employed during the COVID epidemic and have published and will be presenting some of these at European Society of Regional Anaesthesia meeting. Artificial intelligence, which one of my colleagues is very much involved with, and I have been involved in some of these, and eye tracking, and then alternate reality simulation, and I would say VR. And that is one of, during the COVID epidemic, I needed to find another way of teaching because the cadaver labs were closed. And that's where I found Organon and approached them as a company and asked them, can we try and look at using their software? However, apart from the hardware interface limitations, just reading this off, studies in virtual reality education identified 4 concerns: overhead costs, which I'll just touch on briefly, usability of the hardware and software, lack of feedback and lack of engagement, okay, and some side effects. But there's a vast amount of ongoing research. One of my colleagues at Imperial College London has looked at teaching anatomy using virtual reality, and with medical students, and they've definitely seen an improvement, if not the same as you would with cadaver teaching. I know there's a large study in Nature that was done in Greece, in fact, where they looked at VR teaching or 3D software teaching, and it was just as good, sometimes if not better, than cadaver teaching. So I don't think these are gimmicks. I think they are real things we can use. And that is where we then decided to look at a small study, a pilot study using the VR and Organon software, where we evaluated the usability, the acceptability and effectiveness of virtual reality to assist sonoanatomy teaching on regional anesthetic courses. This is unpublished work. It should be published shortly, but just to give you a bit of background, we looked at the usability using virtual reality sickness questionnaires, minimal side effects on most of the participants, and anyone that did have any form of side effects, as I said, was minimal, resolved very quickly. So it is usable. Acceptability, is it something that people find useful? And we use client satisfaction questionnaires, and basically everyone found it very satisfactory. Most people found it great and said they definitely want to use it in the future. And effectiveness, we just set a benchmark from previous papers that we wanted to see a 30% improvement in test scores where there was an improvement of at least 30%. So if you think about it, someone that only knows 50%, they jump up to 80%. However, the key here is it the same? Is it better than using models or cadaver teaching? With our pilot study, it didn't show any difference, but I make that clear. It's a pilot with 20 participants, and this is, it's just a pilot to show that it's no worse, and hence we will now be looking at a randomized controlled trial. So my experience, our experience, anatomy, sonoanatomy, it's basically come from using 2D drawings, sitting in cadaver labs, and now I've moved on to using 3D or VR to try and teach my trainees, teach my fellows, and actually even fellow consultants that have done small courses and small group teaching. So moving on from there, as an example, we run this course once a year. We are looking to increase that now, but this is something that all our trainees in our region go on, and this is where we ran our little study. So traditionally, as you can see, it's one of my fellows. I'm there in the background with the VR headset. teaching the trainees with 2D drawings and sections through anatomical slices. However, we incorporated virtual reality teaching into these courses. And here you can see myself with two fellows setting up the VR software, and me in the background. You can see the anatomical models, and this is how we were then using small group focused teaching on the course. Very well received. Everybody thought it was a fantastic idea. This is where we did the Versailles study. So we'll be publishing those results shortly, and definitely moving on to looking into a randomized controlled trial as regards the acceptability, usability, feasibility. So this is just in terms of using VR teaching and anatomy and sonoanatomy for regional anesthesia. I've used it for teaching trainees. This video, which you'll see, is during COVID times as such, teaching people across a platform. You can use MS Teams, you can use Zoom, whatever you decide to use, but using the Organon software and then using sonoanatomical clips, pictures, etc. And I suppose what rings true for me, it's basically almost happened every single time I've done these teaching sessions. And the one statement that rings true is where the trainee said, you know what, a light bulb went off. I now understand the axillary brachial plexus properly, and how everything sits and how everything's orientated, looking at that 2D image on ultrasound, having done the VR sessions. So with no further ado, I'll just look at that very briefly for you. I'll just have to turn the volume off here because it can just interfere with everything. But yeah, you can see what I did with this specific one was cast it as well, because one of the trainees, silly enough, didn't charge up their headset. So they could still get the teaching, albeit in a bit of a 2D environment, but everyone else is wearing headsets. And here we're teaching what's called an erector spinae block, a block in the back that's quite popular these days. But then moving on the various layers, bone, muscle, skin, and then the various anatomical aspects that would be associated with trying to perform this block. And I've now got the people wearing the headsets in this immersive environment where you can see I'm going right in there, zooming in, and I'm showing the person that's not wearing the headset the various aspects of the block and how to identify this on an ultrasound. Subsequently to having done all this VR, we then look at sonoanatomical pictures, we look at blocks taking place, and now we relate all of this information to what we've seen in that 3D environment onto this 2D pic that sometimes people struggle to interpret. Whereas now, after having done this, the trainees can really and truly, and have said to me every single time, I now understand what you're talking about, what this peak, so to speak, here is. As an example, you can see the cursor running around trying to explain all of this. So our setup with regards to Organon and what we went about. So I had very little money. Basically, the money from the courses is a charity that we run. And I had to look at inexpensive options. So we went for the Oculus Quest 2 headset. I mean, there's a range of headsets out there. I'm not saying that this is the headset you must use, but I'm saying this is what suited our application. And I wanted an untethered application that does give you some limitations, which Organon can explain to you better than I can, but in terms of the software, but in terms of our application, it was perfect. And the reason for that is we wanted something that was extremely portable, transportable, and I could take it anywhere without having to plug into anything. The only thing that I haven't put on this presentation that we did do, and that's not an unlicensed form of use, is we just bought power banks and attached that to the headset if we were going to use it on a course for a whole day. But I can't say that that's something you must do. That's something I've found out on YouTube myself, and we have done that with success. The 3D Organon software, again, I paid for the software, so I haven't been given it for free. And essentially, we went with a standalone premium subscription. That's the one I use to be able to teach in that 3D environment where I can set up a classroom, and then I have the trainees. All of those trainees that you saw in the video were all sitting at home, in fact. So, you know, we were doing this, everyone sitting in their home, doing the teaching and running through all the sonoanatomical aspects of the nerve block that we were doing. All the trainees have a standalone standard subscription where they can log in at any time at home as well after the teaching and run through it themselves as well. The other thing is you need a reasonable internet connection. So that's one thing. And I guess, you know, living in the UK, pretty much anywhere we've got a decent internet connection. So you just have to, depending where you are in the world, look into that. And your communication. I mean, you know, there's lots out there. I'm not promoting one or the other, but I mean, we're doing this on Zoom. My trust uses MS Teams, and hence we use MS Teams. But I mean, you can use any platform that suits your needs. As such. And a portable ultrasound, that is something that, you know, we've given our trainees where they've got a butterfly and they can scan family members themselves, etc., and continue their learning. And, you know, I've had some of my fellows say, you know, they've been on the Organon software, run through it, looked at all the anatomy, and then actually quickly picked up the ultrasound and scanned themselves so that you can integrate that learning straight away. And they have found that extremely useful. So some of the advantages, I would say, cost for sure in terms of our setup. As I said, the Oculus Quest in the UK, buying one of those headsets is, I would say, to some of the top competitors, is probably 5 to 8 times cheaper. I suppose when I bought it, it was an Oculus Quest, but I think we call it Meta now. So yeah, you know, we bought 5 of those headsets, one from me as the trainer, and then 4 that I could, because I normally have around 4 fellows a year. It's remote, it's transportable. There's after teaching review with the software, the 3D Organon, you know, whereas, as I explained, the trainees go back into it and play around and then quickly take their ultrasound out, scan and confirm what they have just learned. Disadvantages with the Oculus Quest setup or Meta, you need a Facebook login. I suppose some people may not want to do that, but the issue I personally had at the time was I had to log in with my Facebook login into each of the headsets. I had discussed it with the university, they were looking into it. Unfortunately, they took far too long to come back to me. So I just logged in with my own personal Facebook login account. So I had to just stipulate to the trainees when they have these headsets at home to use them appropriately. Your organization's internet can be problematic. That is something I did face with the filters. With the uni, you have EduRoam, and some of the filters may not allow the software necessary to go through that. However, we use the NHS internet, and then EduRoam came back to me a while later and said they'd fixed all the filters, but I mean, I've never had to go back and sort that out. So that is just something else that one would have to look at. So this is something that Organon, I believe, are releasing or have released. I personally have not had a chance to play with it. As I said, I don't get money from them. I have to buy my own software from them. But I think this definitely has promise in terms of regional anesthesia using VR ultrasound simulation. You know, and I've had discussions with Organon where I'm going to try it out, and obviously, if it suits my applications, buy a license. But I definitely think this is the way forward for me in terms of that, where they can play around with an ultrasound and look at the image, and something that we call dynamic scanning, where you move it around versus a static image. I think that is something that can definitely move forward. And I have spoken to them about possibly looking at a regional anesthetic application, but that, I mean, that's very, very specific. So that's way in the future, I guess. But this is something definitely that to look at in the future for my application in terms of regional anesthesia. And I guess that's a summary of my application, my experience, and what we've done using VR anatomy versus going into cadaver labs. It has many advantages. And as I said, the trainees have said it's a light bulb has gone off for many of them each time. And I have definitely seen that in the theatre environment post-teaching, where I would usually be pointing a lot of things out, where they would then be pointing things out to me, which is definitely what you want to see as a trainer. And I guess that concludes my chat. If there are then any questions, I'll just hand back over to Organon, and if there's anything specific that anyone wants to ask. Thanks very much.
Dr. Bellew, thank you for that. That's amazing. I think anyone who followed your presentation can only benefit from your insight and your experience. So that concludes the presentation part from the webinar from Dr. Bellew. Now we're open to a question and answer section, our Q&A. I'm sure Dr. Bellew would be more than happy to answer any questions, queries. So please don't be shy, fire away. Thank you. Anyone? Dr. Bellew has been kind enough to provide his contact details, his email, so you can always contact him should you require any further information. But it would be, this is a nice setting, a live setting where, as I said, it's a great setting for Dr. Bellew to answer.
Okay, so I think there's someone's written something in the chat here.
Yes, Alexander Christovi. All the students were in the Oculus Quest 2 and all were logged in using your Facebook account?
Yeah, well, I suppose, that was one of the limitations I had with Oculus. I actually had meetings with Facebook, I'll be honest, and I actually contacted them in the States via Oculus Quest. And at the time they said that is, there is an alternative you can do or get a subscription license, but that is industry. And as I said, I'm a researcher, a clinician, and I don't have funding for that sort of stuff, and the license is very expensive. Where then it would be cross-platform, but I mean that's for big business. So yes, I bought the 5 headsets, logged in with all my Facebook logins, and I handed over to the trainees with a trust aspect that they then use it appropriately, and I haven't had a problem at all. But yes, they were all logged in with my personal logbook Facebook account. I had approached the university because I've been told that the unis, some of them have these blanket Facebook accounts that can be used. But as I said, unfortunately, the university took far too long, and it was in the middle of the COVID epidemic, and I don't blame them. And hence, I needed a quick solution. And Organon remembers when I contacted them during that time, they were very quick off the bat to help me out, but I just had to proceed. So yes, they were all logged in with my Facebook account.
Hello, Chris. Chris Bishop is asking, what are your go-to modules within 3D Organon that you use during teaching?
Well, I go to when you're in the 3D Organon at the top in the regional sections, I actually break it down and run through the layers. So I will start off with muscles. Okay. Initially, when I did this teaching with some of the fellows, I would just get the whole aspect, let's say, of the brachial plexus. And at times it was just very busy. So what I then do is I go for something big first, and I go for muscles because that's very big and easy to see on an ultrasound image. And I then explain to the trainees what you would then see. And then slowly I build in vessels, and then I build in the nerves. So that's how I would do the teaching in a layered fashion. For example, the lower limb, doing what we call a popliteal nerve block. I would then start off with muscles. I would then sometimes bring nerves in. I'd then remove the muscles, leave the nerves there. I'd then bring vessels. So I do it in a layered fashion as such for them. And I'll just take out the regional sections in terms of those modules. I hope that answers your question. Okay.
Alexander, hello, Alexander. He's asking, I thought you cannot use a few headsets simultaneously.
Well, if it's pertaining to Organon software, yeah, well, I have the license specifically to create a classroom, and then I give the trainees, where they have a student license, the password, and they log in, and then it's multi-user. So yes, that can be done. But with regards to the Meta or Facebook, Oculus, if that is what your question is, I've logged into all of them with my own Facebook login account, and there's no problem.
Okay. Konstantinos Panagi, hello Konstantinos. He's asking, he's saying, I've come across a number of different groups / people / consultants from Imperial trying to do something with AR, VR for medical use / teaching. Is it the case that all these groups are going on their own path, or do you all communicate together? As each group seems to have good ideas, but going different ways.
Yes, that is true. I mean, you know, I would say, one, we communicate, and two, we do go different ways as well. And the reasons for that is our applications are vastly different at times. Okay, so if you're looking at a surgical application doing laparoscopic surgery versus, I mean, a regional nerve block, we're only going to be in very, very specific areas versus an abdominal area. There's some overlap with regards to, let's say, they're using you know, their instruments for laparoscopic surgery and us using a needle specific. There may be some overlap, and we do chat to that. There is a hub at Imperial for VR and AR that people do communicate, and I am in discussions with some of those people. The next thing that I'm actually looking at, that is a bit of hepatic feedback using VR. So we do collaborate, but yes, we also do go in different directions at the same time. I would say, you know, that is one thing Imperial allows. They don't say, well, we must all go this path. Everyone does everything, but at the same time, yes, we do communicate. However, with regards to the COVID epidemic recently, some of that communication, for obvious reasons, has been difficult. I do find sometimes a face-to-face chat with these sort of things can be better at times to try and discuss and do these things. But we are going in different directions, but also communicating. I hope that's answered the question.
Great. Robert H. Hello, Robert. Thanks for this presentation. In the model you showed it, oops. In the model you showed, it looked like there was some lag or lack of smooth movement. Also, the model appeared somewhat cartoonish. For example, Jura as a uniform blue tube. Do these elements interfere with teaching at all?
So with regard that is purely, it would be one, an internet connection thing. Two, the hardware we are using. Okay, because don't forget, I'm using the Oculus Quest 2 in terms of its hardware and what its capabilities are. If you're using a much more expensive, high-powered headset that's maybe tethered, it's a little bit of a different experience. So we have had lag in terms of internet connections when I've been in some of the hospitals, but it hasn't really interfered with the teaching. And when I say lag, I'm talking seconds, not even. So no, that hasn't really interfered in the teaching in any way, shape, or form. The one that I was using was casting, and that was via my computer that unfortunately at the time was a bit slow because I had so many things open and I don't have enough memory. So that's a personal thing. But if I was using my, and that's on my laptop, but if I was to use my desktop at home, which I'm moving to, that problem would be resolved straight away because it's far more powerful. So that's really just a hardware thing. In terms of cartoonish, no, none of the trainees have complained about it. I mean, I'll say straight, one of the trainees, before we even started, they'd never ever seen the software. They went, I'm a bit worried that this is gimmicky. And I said, that's fine, not a problem. Let's look at it, let's run through it and see how you go afterwards. And the words from the person was, let me just try and do it word for word, was surprisingly, that was very good. I didn't expect that. I think that's exactly the word. So No, I don't think it impedes teaching. I think it can only aid. And don't forget that I would say this is an element of regional anesthetic teaching. It's not the one and only. You know, there are many aspects to it. But what I'm trying to do here is to have people understand the 3D and overlay that onto that 2D image so that they have that integration and understanding.
Fantastic. Konstantinos Panagidis is back again. Many thanks. I might pop you an email later on.
Sure. Anyone that wants to email me, no problem. It's boyne.bellew@nhs.net. Yeah.
Yep. And if he needs to get in touch with me also at 3D Organon, he may. So that's by all means, Konstantinos, it's fantastic. Chris Bishop, thank you. Regional leading to muscles, then add in vessels and nerves makes sense. That is helpful. Oftentimes I have students who want to use our 3D Organon on their own, i.e. not directed by an instructor. So sometimes I struggle with giving them the proper setup when they are doing it on their own. So I'm pretty sure he's referring to self-directed learning, because we do advocate for both 3D Organon for teaching and also for self-directed learning. So yeah,
my trainees or fellows as such, we do directed practice, and then I say to them afterwards, go over some of the things we have done, which they all do in practice, and then they come back to me with questions. So I mean, I give them the headsets and the software and allow them a play way before we start any of the tutorials, so that they can also get a feel for the software as well. So it's not a first-time experience, you know, that sort of thing. So generally, they get the headsets right at the beginning of their fellowship. They play with it a bit, get a feel for it. I give them tasks in terms of certain aspects of anatomy to go through. You know, I must emphasize, for example, we've got a Dropbox folder that we've created, and they run through, you know, there's worksheets that they run through, that sort of thing, together with the headsets, and read up and go and confirm all of this information. We then I run the tutorials with the fellows, and then they then do some self-directed learning as well. And I'm always at the end of an email, I'm always at the end of a phone for them, I'm always there in theatre, and obviously they are on lists with me as well, and we continuously then run through all the bits and pieces to ensure that it's all solidified in terms of their fellowship. I mean, they're with me for a year. So, you know, we run through it all right through until the end of the fellowship.
Fantastic. Robert H says, thank you. Well, I thank him too. So thank you, Robert. Konstantinos is saying, what is your email for 3D Organon? Can you type that in? No? It's just 1 second. Konstantinos will just try support at 3D Organon. No, okay, 3D.com. Give you time to get that. I'm Theodoros. Just everyone calls me Theo. So just use that email, direct it to me, and I'll be more than happy to reply and see what I can do to help you. Fantastic. Thank you too, Konstantinos. Oh, there's from our marketing manager, Hello Konstantinos. She's also supplied the email. Thank you, Tatiana. Further questions? You sure, anyone? It's the best setting now live. Alexander says, how many people were logged in with your Facebook account simultaneously?
5.
5.
So my account, and then I've got 1 logged in for each of the headsets. I bought 5 headsets.
Okay.
So, I mean, with regards to that, that's not really an Organon problem. That's a Oculus Quest 2 Meta problem. And as I said, I'd researched many forums, looked into this, where you share games and blah, 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 and all that sort of stuff. But I haven't had a problem.
There have been issues with multiple devices recently, where multiple devices registered under one account using the same software simultaneously, not just 3D Organon software, any software can encounter an issue or a problem. This was brought to our attention from a couple of our partners, universities, and one university in Canada, Georgia College, they actually came back with some great feedback. They found a third-party vendor called ArborXR. I'm not advertising Arbor. There were many more also. We have no vested interest in that. I'm just giving solutions to people who inquire. This is a third-party vendor. It's called ArborXR, and they provide like device management for multiple devices when it comes to Facebook VR headsets. So I'll be more than happy to provide any more information on that, and then you can do from there. You can take it on. You can pursue that. So that's some piece of information I'd like to share with you. Great. Anyone? You sure? Fire away, don't be shy. Okay. I think we can safely say that that concludes the Q&A part 2. I would like to say that just some closing, unless Dr. Boyne, you would like to say something also?
I mean, I just hope the chat has been useful, you know, and people can take what I've said and use it for their own applications. And as I said, you're more than welcome to contact me via my email. And I'll try and answer any questions I can, but thanks very much.
Thank you. As I said, I'll just use some closing remarks here. Yes, virtual reality is the natural next step for the evolution of medical education and training. And the benefits from the advantages of immersive learning and teaching XR technologies are absolutely enormous, immense. And this is where 3D Organon comes in. It's not about what 3D Organon does to you in terms of what we bring to the table, what we offer, but I do emphasize that it is about what 3D Organon can do with you in your education programs and in your activities. So please get in touch with us and we'll take it from there. I would like to, from the bottom of our hearts, on behalf of myself and 3D Organon, thank Dr. Bellew. I know his time is very valuable. He's working between surgery and his classes. So as I said, Dr. Bellew, that's a very warm welcome to you, a very warm thank you to you. It's much appreciated. I am confident and sure that anyone that followed this, your presentation today and the people who will be following it on after this can only benefit from what you had to tell, from what you had to say. So thank you again. Take care and stay safe. Thank you.
Thanks very much, everybody.
You're welcome. Thank you.
Bye-bye.
Bye, but take care. Bye-bye.